Good morning. I'm going to ask you to take a seat. I hope you have your coffee. Thank you for being here bright and early on a Sunday morning. I am Tammy Kerr, and I am the president of ANA, and we are delighted to have you here this morning. We are going to present a panel presentation on advancing American kidney health, ANA's current state of action regarding this executive order that was signed on July 10th of this year. To my left, I have two members of the panel, and perhaps at least one of these members is a familiar face to you. To our left, we have Jim Twiddell, and he is ANA's health policy consultant. He works in Washington, D.C., so he's in the middle of all that occurs, and he has been an invaluable member as we have looked at as an association what the signing of this executive order means to ANA and potentially what it means to nephrology nursing. He also holds the role as Senior Vice President of District Policy Group at Drinker, Biddle, and Reith in Washington, D.C. And I believe we have a number of individuals in this audience who attended the health policy workshop that we held at his office this past June. In the middle, we have Donna Bednarski. She's a past president of ANA. She also serves as ANA's consultant to Kidney Care Partners, and she's going to be speaking about her role with KCP. She's also a nurse practitioner at Harper University Hospital Dialysis Access Center. And I am Tammy Kerr, associate professor at Villanova, your current president, and also research consultant for Mainline Health System. The three of us have been working closely together also with a number of other individuals in the room, and I'll address the work that some of the other individuals in the room as ANA members have contributed to this effort over the past couple of months. But the three of us have been working very closely together to look at not only the executive order, but the ESRD treatment choices model and the QIP and PPS, and we provided a response to CMS on both of these. So I am delighted. Jim is going to start this presentation by providing to you the background information on this executive order, Health and Human Services' three goals that came out of this, and then Donna is going to then take it and bring that into KCP as well as ANA's response, so to speak, to this executive order, where we are, the collaborations that we have started to form, and the responses from KCP. And then finally, I will conclude by pulling this together to discuss philosophically and from an action standpoint how ANA is responding now, has responded, and how in the future we intend to address the sometimes vague executive order and these particular goals. And then we will have time at the end to use the middle aisle podium mics for your questions and answers. I'd like to let you know that this session is being recorded. So please keep that in mind. If you wish to share this with your colleagues, they will be able to go to ANA's website and they will be able to to listen to this session. I would also say if you come to the middle podium mics and ask a question, that you try to ask that question clearly because we are being recorded. And if that doesn't come out that way, we'll repeat the question for you. So I'm going to pass the microphone, so to speak, and the clicker to Jim Twiddell, and we're going to stay seated because we also want this to feel like kind of an informal information sharing session for you. So here we go. We're going to get started.
Thank you. Good morning. So I wanted to start by just clarifying a few things about the executive order and providing a little overview of the goals before we get into the details that are available on it. But first, I do want to say that the executive order, or the Advancing American Kidney Health initiative, is one of the most significant policy proposals for the kidney disease and ESRD that we have seen since the Medicare ESRD benefit was created. The goals obviously are ambitious, to say the least, and broadly speaking, it's to move dialysis from in-center or more of it to home dialysis, to increase the availability of kidneys and to increase the number of patients who are receiving transplants, all with the overall objective that continues to be the same regardless of the policy, which is to reduce cost and improve the quality of both patients' lives and the quality of the care that they receive. However, it's really important to understand that when we talk about executive orders and some of the stuff that I think sometimes can be a little bit boring or tedious, particularly when you're focused on Washington, D.C. or the federal government, which is what's an executive order, what does it really mean, and how does it impact everyone's lives, and is it different than legislation or other things that we talk about in regards to policy. So I want to go over just a few of those differences and talk a little bit about executive orders. I think everyone's familiar with kind of how a bill becomes a law. I think when you think of executive orders, they're very similar in some ways of how they're implemented. However, it's not something that Congress has been involved in at all. The President of the United States is given the ability to issue directives to the agencies that he oversees, in this case, the Department of Health and Human Services and the Centers for Medicare and Medicaid Services. And they implement, the folks at those agencies implement those directives in the same way that they might implement a law that Congress passed. However, it's not something that's gone through Congress. The people that you've elected haven't necessarily contributed or been a part of the development of this type of directive. Executive orders have become quite popular in not only this administration, but in previous administrations. Presidents use them as an opportunity to advance policies when Congress is sometimes either politically not of the same party or unwilling to take on certain challenges that are goals of the president, but not necessarily items that are going to be easy or quick to try to get through the legislative process. Both President Obama and President Trump have used these. You've seen even in the past week or two, President Trump issued 2 other healthcare-related items through executive order that are related to Medicare policy. And so while the implementation is similar, as well as Congress can pass legislation to strike down certain executive orders, and also the courts can overturn them, they have that similarity. But what's most significant is a lot of them are overturned when you get a new administration. So as soon as if we have a new president, either in 4 years or 8 years, if that president is of a different mind, of a different political bent, they may decide to try to reverse certain items within executive orders. However, within this particular executive order, we believe that the goals that have set forth, while ambitious, are something that aren't necessarily controversial. The objectives are items that I think the community overall is supportive of. The question is, what's in the details and exactly how are you going to do it? And both Tammy and Donna are going to spend a little bit more time on that. The rationale, the overall, I'll say goals, we're going to talk about the specific goals that are cited. But when you look at what the president announced, when he announced the executive order, what he focused on, and I think everyone here and everyone in the community can agree that the idea of the number of people with CKD and ESRD in this country is high. Everyone in this room is focused on all the efforts to care for those patients and try everything that they can to lower those factors that lead to these diseases. But at the same time, we want to increase options that patients have, give them opportunities to have different modalities of care, and try as best we can to also provide opportunities for patients to have kidney transplants. The question is exactly how do we do it, how do you implement it, and how do you do it in a way that allows, particularly in our case, nephrology nurses to provide the highest quality care they can and not be limited or in their jobs be overworked in certain ways that aren't safe for the patients or safe for them. Again, one of the details that we're going to cover a little bit as we start to talk a little bit more about the executive order. Goals. To be a little bit more specific on the goals that were stated within the order, reduce the number of Americans with ESRD, move to 80% of new ESRD patients going to home dialysis by 2025. So again, I'm sorry, the first one there is the goals and the aim is by 2030, the second 2025, and to double the number of kidneys available for transplant by 2030. So in a very short period of time, we're talking about how ambitious this is that they want to reach these goals, which are laudable, but at the same time, how do you get there? And are we going too fast? Is the year and this goal achievable? Something too that continues to be determined, and more details are needed before we're able to know if that's something that's achievable by practitioners. Particular objectives within each of the top 3 goals that were listed by the President within the executive order. And you can see here evidence-based intervention, surveillance capabilities, all things, again, we're going to need more details on, but at least have been put forward. The second goal we have more information on, and also have already started the policy process. And I'm going to mention a little bit more detail about the payment end as well, but in this case, coordinated care, increasing education for patients and caregivers is something that I think everyone here in the community has been supportive of, and payment models, which are around value-based care, which we'll go into a little bit more detail, where they've actually put some details and put out a policy proposal, and that's an area where they've already started to move. We're looking to see other proposals, written proposals in these other areas, hopefully in the near future. But putting funding towards Kidney X, which I hope everyone here is familiar with, is something that ANA has been very supportive of, and I think the community has. It's something that's a partnership between HHS and other groups, and something that we've been supportive of, and Congress is now starting to put a little bit of money behind, which is encouraging. Third item in the transplant space, again, we mentioned some of the specifics on the goals and objectives of this, but looking at just objective recruit, increasing number of living donors is something that, again, we've worked on for a number of years legislatively, and I think it's something that the community's been behind. What we don't know is has this executive order helped us spur more people in Congress to get behind the Living Donor Protection Act? We'll have to see. But again, objectives that we've been supportive of, the question will be, how are we going to go about achieving it? So the one area we do have some details, and where ANA has had the opportunity to provide a point of view and provide written comments to the administration, is on the treatment choices model, the ESRD treatment choices model, or ETC. Both Donna and Tammy will provide some more details about this, about the community and about ANA, but we've had the opportunity to provide our comments. They're on the ANA website. I'd encourage you to take a look at those, to look at the executive order, but also take a look at where ANA is on this proposal. There are probably a lot more questions that we have than answers that were provided in it, and I think our letter is something that the organization could be proud of, and also is a first step. It's a first step in putting forth a policy position, and it's the first policy beyond the executive order itself. Is the first rubber meets the road kind of policy proposal that the administration's put out. We expect there to be more in the near future, and we also did work with coalitions such as Kidney Care Partners and the Alliance for Home Dialysis in their response to this particular rule. And we expect a final rule, meaning CMS has listened to the comments of the community, and this is their response, and this is the policy, the revised policy that will be implemented. We don't know when a final rule is going to come out. We can't guess necessarily, but we hope that they will have taken into account the views of the whole community. And I think in many ways, we're the one organization that's really focused on nursing workforce issues and those elements of what's in the proposed rule and its impact. And again, I'd encourage you to take a look at that. And Donna is going to provide you a little bit more detail as we move forward. So I'm going to hand it over to you.
All right. I represent all of you on Kidney Care Partners. So let's start with who they are. KCP was formed in May of 2013, and ANA has been a member of that organization since that time. And it's a coalition of patient advocates, dialysis professional, care providers, and manufacturers working together basically to have one voice to improve the quality of care for individuals with kidney disease. Our mission is to involve all of us that are involved. And again, we have patient groups, we have provider groups, we have the manufacturers, small dialysis unit, large dialysis units, to really look at improving and making sure patients receive optimal care. They live quality lives, making sure that care is readily accessible, because that does actually come up quite a bit, and really start to look at a research and innovations focus. There's never been a lot of money put in innovations and research in this area, so we really try and promote that. As you can see, there's 35 members of KCP, and again, we come from all areas, and ANNA is the large nursing group. So it's very nice to have us at the table and have our voice heard as we move through things. It has been a very exciting time. It's been a very busy time as we begin to look at improving kidney care. Starting in April of 2018 was Kidney X, and as Jim was saying, it really does try to move innovations forward by providing some funding. It's a very innovative public-private sector that actually came from the American Society of Nephrology trying to match funds, and we're now starting to get government funds for projects. So it is actually open to everybody, so if you've got ideas or suggestions, you can actually apply for their awards. And again, it's tried to push innovation faster through the system so that it comes out, because there's never any money there. KCP actually also created legislation, and it has been introduced in the House and the Senate. We came up with a framework model for care of patients called Kidney Care First, which actually, when the Advancing Kidney Health Initiative came, it looked like they read our Kidney Care First when they announced it. So we're very excited over that. And then, of course, we have our annual updates to PPS and QIP, which had to be addressed this summer as well. So it's been a very busy summer, and somewhere I fit in there a partial knee replacement, and fortunately all the deadlines passed when I had my first grandbaby, so. Kidney Care First is really a framework for the future and what the priorities are for kidney care. We had a blueprint a few years ago. Of course, everything gets outdated, so we moved into this. The acronym is a framework for improving renal disease support and treatments. Yes, I did say renal. I know it should be kidney, but the acronym wouldn't make sense if it were frisked. Okay. So we did do that. It was a very bold framework that we put out there, so it is on the KCP website. I encourage you to check it out because it's actually pretty exciting. Our legislation, again, has been introduced in the House and the Senate, and it's a bipartisan bill. We kind of have a kitchen sink philosophy. Pretty much anything of priority is in that bill. It's very tedious. We never expect anything like that to pass. But we do hope that our priorities are in there. They'll take pieces of it over the course of the year and house it in other bills that are moving through the health policy system. So again, it's all on their website, or you can actually Google it and check it out for yourself to see what our priorities are. We also initiated a PR event over the course of the year. We started in January. KCP is going through a rebranding and bringing it to the forefront, which is why all this has been very, very timely. We redid the website, which is a wealth of information, and it's worth going there to check it out. And then we've really been getting kidney disease out on the map and really pushing it forward. They're also on Facebook, so if you're on Facebook, friend them on Facebook, and you'll begin to see some of the things that we do. And it's not just advertising Kidney Care Partners, it's actually looking at kidney disease and prevention, which of course made it extremely timely with the Advancing American Kidney Health Initiative. And it really is in line with our Kidney Care First initiative as well. So it's pretty exciting that, that these initiatives are moving forward. However, the devil is in the details, right? The proposed rule came out that now will tell us exactly how we're supposed to implement this and what some of the expectations are. And whenever we look at these proposed rules, we spend a lot of time to look at what is it supposed to do? Will it meet those goals and objectives that were set forth in the executive order? And then we always look at what are some of the unintended consequences, because they're usually there somewhere. And so we have to make sure that we meet the goals. Are the goals realistic? And then what could possibly go wrong? So when we look at the intended consequences, of course, the intended consequence was to increase patient choice. When you look at numbers of 80% of patients expected to be in home therapies and transplant, does that give them a lot of choice? I mean, why aren't we at 80% now if they're choosing it? And we know there's a lot more barriers than that, but Currently, we have just over 11% of patients on home therapies, which is about 55,000 patients. So where did they get 80%? And there are areas in the world that have. Hong Kong brags 80% home therapies, but that's only 4,000 patients. So we need to put it into perspective of what we can really do. And are we really addressing all those barriers that are associated with home therapies? And anybody in home therapies could probably already rattling them off in their head. One, of course, is patient choice. We want to make sure they want to do home therapies. We have to keep an eye on the failure rates. What about some of the I work in inner city Detroit. We have some socioeconomic issues about getting people to home therapies. I have a lot of patients say I can't do PD because they just don't have space for supplies. You know, these sorts of things that need to be taken into consideration. And what about those patients just are not candidates for transplant or home therapies? Where will that fit in? Where will it fit into the measures? Do we just exclude them? You know, so that gets a little bit complicated. Are our providers, are our physician group colleagues actually prepared to educate patients to move them into a choice of home therapies? I know where I work and I can tell you no. So patients are not offered those opportunities necessarily. And then we have to look at, is there access to care? Do all of our patients have access to home therapies and transplant programs? What about our more smaller facilities, our more rural areas, and how does that impact? And, I mean, looking on the flip side, are our home therapy programs and our transplant programs ready to take on 80% of the patients? And then again, we need to look at the failure rates of home therapies, and are those being addressed? I mean, we got a lot of caregiver fatigue. Are we looking at respite programs? Are we looking at transitional care units? That's been a kind of a topic in our area, is building transitional care units where we could actually train more caregivers. We might be able to use that for respite care, but then we have to look at who's going to pay for it. Who's going to staff it? Do we have staff that are readily available to work in these type of settings? So there's a lot of unknowns at this point. And then who will be impacted? Well, they're stating 50% of the patients will be selected for these type of programs. And is that really realistic to put all these patients in this model of care from the start? They're looking on the use of hospital referral regions, HRRs. And one of the benefits of KCP is we have the opportunity to use consulting groups and statisticians and stuff that are way over my head. Half the time I don't know what they're talking about anyway. But they give us the bottom line. And when they looked at the HRRs, they clearly do not reflect practice patterns and referrals of nephrologists and facilities. So we're kind of picking that to choose this 50% of the patient population when in fact it won't be reflective of 50% of our patients. So that's a huge issue. With KCP, we found it a problem that they're lumping home therapies with transplant. They're two big different animals. So 80% of what? Transplant have a few people on the list today. How is that, going to impact the ability to get these incident patients to 80% numbers? So we're recommended a 2-track proposal. So there'll be parallel that will have home therapy separated out from transplant, looking at a 3-year study and possibly increasing that another 2 years so that we can collect enough data to see how we're doing and what works and what doesn't work. So we're trying to propose alternatives to make it work. Okay. The other thing is we recommend reducing the size to 25%, making it more manageable, more trackable, and then actually getting rid of the HRRs and making it a percentage of the Medicare patients and having it more randomized selection of facilities. And they actually created a model on how to do that, so it's a covariate selection of facilities, so that would be more representative of all of our patients. And then you have to look at the measures themselves. Are they reliable and valid? KCP has always supported the use of the National Quality Forum measures because they are proven to be reliable and valid. The downside to nurses is there's not a lot of nursing measures there. And that partly is our fault. We haven't submitted measures to them to have them make them reliable and valid. So there's some opportunity for nursing as a whole, not just, nephrology nurses, nursing as a whole to work on these type of measures. But in the QIP, as an example, they will use NQF unless there isn't one available, and then they make one up, and then it's not necessarily reliable or valid. So we don't want to get in that sort of issue as well. And then again, are these numbers achievable? Can we actually get 80%? Does anybody here actually think 80% of the incident patients will be on home therapies or transplanted by the deadline? But what is realistic? Where did that number come from? And I'm not sure we know that. Oops, sorry. I'm not sure we know that. And so how do we know that? And that's kind of what we're recommending, is to use a methodology similar to the attainment of the QIP, where we look at thresholds and those kind of things, always pushing to increase those, but making them more realistic. Let's put these things into place that we can grow these programs, address some of the barriers, and then actually continually improve and to see what really is realistic without penalties. And when you look at the measures for transplant, can facilities or providers actually be held accountable for transplant outcomes? And does that even make sense? So we did recommend utilizing more of a referral and wait list measures that, are we referring patients? Are they, on the list? Which is a little more within the domain of the providers. Make sense? Now, the other two objectives were related to the transplant, standardizing the criteria and loosening the restrictions and raising incentives for organ donation, and then reducing the number of Americans developing ESRD by 25%. And historically, we've always focused on ESRD and the payment model. So this will be a huge overhaul when we shift to prevention. And who will be the ones to prevent it? Is it by the time they see the nephrologist, or before that time? So it really does expand payment model thought and concepts. And neither of these have proposed rules yet. So we still have a lot of work coming towards us as we begin to look forward to these showing up at our desk. So there's a lot more to come in these two areas. So what are some of the unintended consequences? What can we be worried about? What do we need to address up front? And of course, will patients be forced into home therapies and transplant? We come from a country that patient choice rules, right? And if we say 80%, are we going to try and shove patients that may not necessarily be great candidates into these therapies? And what will our failure rates look like? And when we look at staffing ratios and staffing patterns, what kind of time and resources are we putting into patients that we're not sure going to make it anyway? And when do we decide that they're failures? How long do we keep pushing and pushing when we weren't sure they were candidates to begin with? So it makes it very difficult, and these are the things that we need to start to address now and start to get prepared for. And at the last KCP meeting, we broke out into small subgroups, and we were the provider group, so there was the one nursing group and the three physician groups that were at the table, and the physicians were like, we have to address the nephrologist shortage. And I said, no, you don't. If you don't have nurses, we don't need you. So we have to address the nursing shortage first, right? I mean, we have a lot of barriers to getting nurses into these therapies and into transplant programs so that we can accommodate 80% of the patients, or whatever that number is going to be. We know it's going to grow. And I don't know where you work. I know where I work. They're not going to hire nurses until the patients come. They're not, is anybody hiring people now in preparation to take care of these patients that may be here next year? There's a lot of, to me, that's a little bit scary. I'm dialysis access, so I'm okay, but I know my colleagues, and that brings up another issue. When we're going to train people on a catheter for home therapies, and then we put in access, then who trains them again? Is that what we use transitional care units for, or will they be staffed appropriately, and will they get paid? So there's a lot of unknowns out there. And according to the Medicare conditions of coverage, in order to work in home therapies, you have to have 12 months nursing experience plus 3 months modality experience. And then how long does it take to train someone to do independently home therapy? So, I think we're a long way out of even ensuring we have adequate staffing in our areas of domain. The other unintended consequence we need to be careful of is with the Stark and the anti-kickback laws. And really they were designed to prevent fraud and abuse so that you could not refer to someone that you had a financial relationship with. But how does that help us now that we need to collaborate more than ever to move patients through systems? We need to be able to share information. So we're asking for waivers for these so that we can talk amongst each other and not get into trouble. Okay? And kind of along those lines, really providing waivers to the restrictions in the kidney disease education benefit. Extremely underutilized benefit that we have. And we want to expand where it can be done, who it can be done with, and the patients that it can serve. So we actually have to have waivers put into place so that we can do that and share information. So I think we're going to hear more about Stark and the anti-kickback laws in other arenas. In fact, we already have stuff coming down the pipeline because the technologies kind of surpass that protection mode. So we have to look to make sure we're not creating our own barriers from our own laws. And then forced penalties. And again, as I said, one of the benefits of having consultants and statisticians, they really look at these measures and the impact, and they clearly showed there's no rationale for the size that they chose and the scoring methodology, and there will be cuts year after year, even with improvements to getting patients to home therapy and transplants. So we have an inherent problem in just the way it's set up. And of course, we do not support a proposal that guarantees cuts to nephrologists just based on having to have so many fail. And that is set in there. So there's some inherent problems in even how it's set up. And there's also cuts, lots of cuts, because they feel the number to the in-center units are going to go down, and they're already planning to pull money out of in-center care. And we have to make sure we protect our in-center patients. It needs to get paid for. But we do have opportunities as nurses with this. We need to make sure we're at the table. We need to make sure our voices are heard. We've only gone through a small piece. We have a lot more coming. Because who knows best how to care for these patients but us? We are there caring for them. They need us there. And that's why I'm a little biased, because I'm your representative for KCP. But we have been at the table every step of the way in every initiative. I've been fortunate enough to be on the advisory committee for the PR initiative. I've been able to help develop some of the education materials. I've been on the advisory committee for the legislation to make sure nursing priorities are also there as well. I've been on all the work groups for the response letters and that sort of thing, trying to make sure nursing is at the table. And we'll continue to do that. And Tammy's actually going to go on more how ANNA's moved in other directions as well. And what an opportunity for care coordinators, trying to get patients through the system. Our educators, what an opportunity to help them. Really, I don't think a lot of patients are given that. When they come to see me for dialysis access, don't even know home therapies exist when they see me. I mean, I do a lot of referral to home therapies, and quite frankly, I'm a consultant. So it's kind of strange, but it works for me. Transitional units. Again, making sure we have adequate staff, but definitely a different part of nursing that maybe you never thought of. A lot of education, a lot of training. So that may be exciting for a lot of people here, as well as respite care. Maybe some home care opportunities to go into patients' home to assist them in that as well. And I think we need to open our own doors as far as that goes. So Kidney Care Partners really does, I believe, benefit ANNA. It makes sure that nursing is at the table for healthcare discussions and decisions. And we provide one unified voice. When we sent that letter, it represented all areas of the kidney community, and I think that's pretty impressive. Again, we work with the entire kidney community. We network with the health providers group, so our physician counterparts. We are allowed a lot of data through the analytics, which is extremely expensive, but we're able to use those analytics to help ANNA move forward. So now I'd like to turn it over to Tammy.
Thank you, Donna. Thank you. Can you hear me? Okay, very good. So as Jim has presented, he's presented the background to the executive order. Donna has started to move into our relationship with KCP and where we sit within KCP. I'm going to speak about ANNA's approach to the executive order and the 3 goals set forth by HHS. So on that day of July 10th, the kidney community, as you probably all know, or maybe you don't know, things kind of blew up, so to speak. There was obviously a high level of excitement amongst the kidney community that we were receiving the attention, our patient populations were receiving the attention, and there was going to be action and movement forward. And so certainly we recognize that level of excitement. But I would also say, as an association, we saw it as a time of cautious optimism for many of the reasons that Donna just described. We knew that there were going to be changes, but we started to wonder, what do these changes mean for our patients, and what do these changes mean for nephrology nursing? So within 48 hours of the signing of the executive order, I got in touch with Jim and I said, we need to have a conversation on the phone. A lot's going on here. I'm seeing a lot on social media. I'm seeing a lot that's coming out as press releases. We need to talk. And in fact, we did it on that very day. And we decided that ANNA's next step would be to pull together a group of ANNA leaders, ANNA members, who were in positioned roles that could act as what I'm calling an advisory group. We have a health policy spin, but we needed a group of individuals who were in roles that would be able to bring the perspectives that they were hearing together for conversation and discussion. And in fact, that group was formed. We pulled individuals who had regulatory, health policy background, advanced practice background, research background in some of the areas that we know would potentially be concerns for nephrology nurses. We pulled our voices together and we got on our first call and we just started sharing. We had a second call, and about that time we knew that we had some actual work that needed to be done. And I'll describe that work as we go forward. And really that work was to address the ETC and also to address the PPS QIP. And so we took this group and we broke it down into two separate working groups. And again, we strategically did that. And so we started to put our plan in place because we knew that we were going to be in this for the long run. We also knew philosophically, as it's been alluded to, that we need to be not just at the table, but we need to be equal partners in these conversations that's going to be occurring with HHS, our kidney care community, as well as our nursing community. So we knew that we needed to take these opportunities to collaborate and engage and run with it. Because if we didn't, we would be dragging along behind the bus. And we know that for these initiatives to be implemented, they need nephrology nurses. So it's also our responsibility philosophically to share the essential role of nephrology nurses and what role we'll play in successful implementation. And what I say to you is there have been numerous conversations that Jim, Donna, this committee, the advisory group, Luann, our interim executive director, we have been on numerous calls with groups, and you'll see the list of groups in a couple of minutes. And one of the things I've learned in speaking to groups, even within our kidney community, is they don't know who ANNA is when I describe that we're an association of 8,500 nephrology nurses, and we work in practice settings beyond dialysis units. They don't know that. That comes as a surprise to them, and it came as a surprise to me. And so one of our responsibilities is to share the roles in which we practice, the environments in which we practice, and the role that we must play as nephrology nurses in successful implementation of these goals. We also knew very early on that change is going to occur and that ANNA will be an active participant throughout the process. And we are working to make that happen, and I'll describe how that's going to happen and how it's going to continue to happen. So the actions that we are taking, as I just alluded to, we formed this advisory group of ANNA members, and the work of that group is not done. There are some of the members within this audience right now, and I applaud the hard work that they've put into this group so far. We've partnered across the kidney and nursing community. We've had numerous conversations. One of the first groups that reached out to us, excuse me, was the American Nurses Association. They actually reached out to Jim Twiddell. He got me on the phone, and ANA reached out to us, again, within that first week of the signing of the executive order, because they started to understand and appreciate the workforce issues that we were starting to understand and appreciate. They also looked at this payment model that was being proposed for the patient population we serve and understood that this payment model may be a payment model that's going to be implemented with other patient care populations in the future as well. So they were looking to us. Very early on, we created that webpage on the ANNA website. You can go right to our webpage, Advancing American Kidney Health. You don't have to search too hard to find it. And we started posting on that website the information that we were receiving from other associations, the HHS rules, so that our members and even our non-members had a background as to what this meant and what we knew at the current stage. We have NNJ and ANNA update articles. If you would like to see the ETC proposed rule letter response that Donna alluded to, go to the exhibit hall, go to the NNJ booth, and the letter is actually printed in the current journal. You can also find it on the website as well. But I also knew that we needed to get information out there as soon as possible. So I started creating video updates in my house, my husband and I. And because I wanted to get information out in short little clips to all of you. And actually, this particular session that's being recorded will become part of that series that we've started. And then, as I've mentioned, we had written responses from the association on the ETC and PPS QIP proposed rules. And again, the advisory group worked hard on developing these responses. I can't, again, stress enough that one of our actions and roles for each of us in this room and beyond this room is to educate everyone about who we are as nephrology nurses and how we practice, and the important role that we must play in the successful implementation of this executive order and the proposed goals. So these are the groups that we've had conversations with. And I could go through and list them for you, but I don't think I need to do that. I believe that you can actually see the associations. You'll see on the left-hand side that I started with the nursing associations. I had the opportunity a few weeks ago to go to Washington, D.C., and Jim and I went out and did some face-to-face meetings. I met with leadership of the American Nurses Association, and we talked about the workforce issues. We know that we have a nephrology nursing shortage. And we have started to look at that as an association. We formed a task force back in the spring, and it launched this particular summer. And again, we have members in this room right now who are part of that task force, looking at strategies that we need to implement as an association to recruit early career nurses into nephrology nursing. We went and visited the American Academy of Nursing and spoke about the executive order. We also, in that week, Jim was on a conversation with on a phone call with the National Kidney Foundation. And we have had conversations with all of these groups, and we will continue to have conversations with these groups, because one of the things we know, and all of the groups are in an agreement on this, one of the things we know is for care to change for our patients, that we need to collaboratively work together. There is no competition, that we need each other's strengths. And I think we are definitely starting to hear that the role of nursing is being recognized, and the strength that we bring to it is being heard, and thus we're being pulled into this. In addition, we're having conversations with industry, with our large, small, and medium dialysis providers, as well as our industry providers on the pharma side, the equipment side, and so on and so forth. And we will continue to have these conversations and develop our strategies moving forward for hopefully success in our actions. So collaborating and communicating, I have a tendency to jump ahead. As I've said, this panel presentation is going to be posted on the ANNA website for you to share. And also, we will have an article in Nephrology News and Issues, because again, we want to get out there to the public beyond ANNA how we're responding to this with this level of optimism, but also in this spirit of being cautious or conservative. As I mentioned, we've had meetings in Washington, and we will continue to have those meetings. One of the things we also know that we may need to do moving forward is when we have lobby days in DC, that we will need to partner with other associations, nursing, patient, kidney associations, so that our voices are collectively heard. And then the American Journal of Nursing also reached out to us, and we will have an article speaking about this and ANNA's position in the February 2020 publication. So continuing actions, we will continue as an association to update our website. There will also be another video update in December, and we will think about how we're going to prioritize our opportunities and collaboration. We continue our conversations with the Alliance for Home Dialysis and ways that which we can collaborate and provide educational programs. The same remains true with the National Kidney Foundation. We have conversations coming up with ASN as well. And so we will take calls from any group that wants to hear about what we do as ANNA and potential opportunities. And we will be strategic. We cannot be everything to all of these associations and organizations. So we will be strategic about the partnerships that we form. And this information will come back to the board for conversation and discussion. With that being said, this summer in July, after the signing of the executive order, our board did a strategic planning reboot, and the Advancing American Kidney Health Initiative was at the top of our priorities moving forward. The New to Practice Task Force, as I mentioned, commenced in May, and we are going to be reinstating the ANNA Health Policy Committee. So currently we have a health policy spin, but we feel, and the board feels, in the current political and legislative and regulatory environment, that we need to move back to the Health Policy Committee. So I'm delighted to say that Donna Bednarski has accepted the invitation of the members of the small board committee to actually be the committee chair of our health policy committee, and we are working on the role description to launch or reinstate the health policy committee come April 2020, and we are working on, once we develop the role description, determining who the committee members will be, and that again is the work of the board. We are looking for individuals who have a strong health policy background and a couple of individuals that we can mentor into the role. We will continue to advocate on the Hill, but as we do that, again, we're looking to do this in combination with our nursing and kidney partners. So I ask you, are you ready? Because there is work to be done, but we are in an exciting time as we move forward. We are ready to go. We are working as an association to provide the resources that each of you need, because it's going to take every one of us in this room and in the nephrology nursing community to be out there and leading this effort. Because if we don't lead the effort, we will be looking back in the future and we will be saying, we were not part of that. How did these changes happen? And then we will have to deal with those changes. So we will continue to provide feedback, and again, we will continue to actively be involved, to be at the table, particularly with HHS. We'll provide the feedback that you need, we'll provide the information that you need on the future changes to the proposed rule, and also our responses to that. So in closing, ANNA and our colleagues in the kidney community, we're all going to continue to work together and collaborate. We will be here as an association to support you and all nephrology nurses moving forward, and we will be here to keep you updated as we learn more. I think, as Jim and Donna alluded to, at this point, there are probably more questions than answers that we have, but I think the one answer that we know is that we are going to stay actively involved, and being at the table is critically important, but also I see that we have a role in leading this initiative forward, because as Donna said, we're not going to be able to go forward with any of these initiatives without the skills of nephrology nurses, and it will fall and it will fail, and so we are needed. So with that, I will close. We have some time to take questions and or comments and or insights from the audience. I would also say, as you in this room and listeners to the audio version, if you obtain information that you think is important for ANNA to know, please bring it forward, because we want to know that information, because it may not be something that we're aware of. So I'm going to turn it back to if you have any final comments, and I'll also turn it over to questions that the audience may have.
Good morning.
Good morning.
Good morning.
My question is about transplant. That's a pretty ambitious goal, to double the amount of kidneys available. I was a transplant nurse back in my history. Is there any movement on doing like a opt-out program as far as kidney donation is concerned? And is that something the health committee is going to look at as well? As far as the state level, the federal level, is there any push to maybe have people have the option of opting out that they don't want to donate a kidney if they pass away?
I haven't heard anything, Jim, of an opt-out sort of a thing, but the rules for increasing have not been released, and I don't expect that to be one of them. I think they're going to look at more at standardizing criteria, which should raise a red flag when you think CMS and HHS are the ones that are going to identify that criteria. So obviously we need to stay very alert as to what that will be, but we'll see. It's a wait and see at this point, but there's no other initiative outside of this.
Thank you.
Mm-hmm.
Hi, I'd just like to make a few comments if I could. You're so on target with everything as a nurse that I see. I was at the signing, and everybody I talked to afterwards agreed with you that the devil's in the details. But I'd like to be a little simplistic with a couple of comments first. How do we get more patients home? I was recently at the ISHD Indiana University conference in Chicago, and Dr. Jose Morfin from here in California made two really, really marvelous comments, I think, that we need to all think about as nurses, and that is that patients live the data. They're the ones that have to deal with it on a day-to-day basis. The other thing he said was that he's gone about things in a much different way. Instead of just feeding information and education, when he sees patients, his quote was, his first thing he said to patients, pretty much the first thing, is tell me about your life, or what do you see your life being? And then goes from there, which I think is hugely, hugely important. And the other thing I want to comment on, and then I'll shut up, who knows best about the care of our patients' need? I think one of the things that we really, really have to consider is the fact that, yes, and I'm being a nurse, this little bit of maternalistic attitude, I have to pause occasionally and step back and go, wait a minute here. But after they're given the proper guidance, and I use the word guidance to include education, information, that type of thing, who knows best what they need? And I think that's the patient and their families. And just as a little aside, people that don't know me, I'm coming from both ends because besides being a nurse, my husband was also on home hemo for 25 years and thrived. So that's what I'm about. So thank you.
Thank you.
Thank you. Can I respond? I just want to make a response to her comment. So in one of the conversations that we had with AAKP, we did a lot of talking about the expertise and the role of the patient. And one of the comments from that conversation that continues to move through my head is that they believe, and I think we'll all agree with this statement, that when a nurse and a patient go to the hill together, there is no more powerful voice than those two, because we have the expertise of the patient and we bring the holistic nursing care of nursing to that. So thank you for bringing that point forward about the expertise of the patient.
And we're well respected on the Hill. Very well respected.
Both patients and nurses, I assume.
Yes.
So thank you, all three of you, for doing this great presentation. I think most of the people in the room know a lot less about it than you guys have studied and learned, and we appreciate it. Donna actually mentioned that there's possibility of CKD trying to prevent progression to renal disease or end-stage renal disease. And the question I have about this, and I know that we don't have proposed rules yet for it, but I'm wondering if congressional action would be required in order to receive payment, if you will, for CKD care. The ESRD program is for stage 5, not for 3 and 4, and if we're going to stop progression, we have to take action in stage 3 and 4, and currently the Medicare program for ESRD does not cover that. So I guess my question is really whether or not that could be handled by proposed rules, or whether payment for education and prevention in stages 3 and 4 would have to have congressional action.
Did we cover that? Did I cover that in the letter? Just one, yeah. I don't know if that was covered in the letter. I think it's a good question. I think a lot of areas that I've heard KCP in particular comment on in relation to areas where they believe CMS isn't following the statute under the original statute in regards to certain areas of payment and also within quality of what they're utilizing. My guess, but my thought is that some of those things could be changed through proposed rulemaking and assuming Congress doesn't decide to let the agency know that that's something that they would rather change. So I think there's probably a right answer to that. My presumption is that Congress would have to pass a law in order to change that. However, as we're seeing now again with executive orders, also with payment rules, that if the agency decides to do that and the community doesn't have an issue or doesn't raise a concern with it, then I think CMS could go forward until they're challenged. That's how. But I don't know how they would choose to, if they would choose to do that first or not.
Thanks.
Yeah, and we didn't really address it in the letter, but there was a lot of discussion on it, making sure that we're ready, because this really will be a huge overhaul of our, CKD system, and making sure that the measures and the penalties, if you will, because this is a penalty program, unfortunately, which it shouldn't be, but it is in the right corner.
And I just want to, one point I didn't raise too, but maybe Glenda's kind of raising as a larger issue, is what's Congress's role in all of this? And Congress hasn't come out and, while they comment on nearly everything every day, this hasn't been something that members of Congress universally, and those that are on the committees of jurisdiction over Medicare payment, haven't necessarily come out. They've been supportive of the general goals and concepts, but to the ETC and those areas, again, things have to move forward, and until the community is engaging members of Congress, which we're at the beginning stages of doing so, will they take particular action on some of those issues that we have concerns about?
Okay, when I first started in nephrology about 15 years ago as a nurse practitioner, I got involved in ANA, and I remember thinking, okay, there must be millions of dialysis patients. But through ANA and everything, I learned that out of the 300 million population in the United States, there's like 600,000 at that time, and now 700,000 dialysis patients. And they take up about 8% of the healthcare budget. And I was like, oh my gosh. So I understand totally, and that was my feelings a long time ago. So this makes sense. But as always, I'm thinking, I see 400 patients a month, and I asked them, what about home dialysis? And it's like I can't even tell you, maybe 10%. So my thing is, how are we going to get 80%? So I started thinking of thinking, well, maybe I can take a survey and, present it. Maybe we're thinking 80% because hopefully we'll get 50%, but would that be a good thing to, maybe all the units, would that be a good thing to present to show all the patients that are willing? And then Gail said yesterday that we have to start with our new patients, just like a fistula. You got to say, my VA patients used to just come with a fistula because that's how it was. So maybe that's a suggestion. We have to start with our new ones, but because the old ones, I don't see how I'm going to get them to do home. So anyway, I was just wondering.
Thank you.
In response to that, the issue about patient choice is significant. The literature is very clear that 3 out of 4 patients are eligible for home, medically eligible for home. And we don't begin to see that. So this issue of choice really needs to start long before modality decisions are made. And modality decisions are not a one-time deal. They're really part of a process of a whole career for ESRD for the patient. So if you are doing education, please, if your patient seems reasonable for home, is interested in home, encourage them. Don't do education as if it were an unbiased issue. I often liken it to going to a financial planner. You go to a financial planner and they can say, well, we can do this, or we can do this, or we can do this. What do you want to do? You don't do that with dialysis options. You need to make it relevant to the patient, to their lifestyle, to their family issues. So if they're interested in home, encourage them, because they need to hear that. They need to hear that from the nurses. They need to hear that from the doctors. And the other thing is, if they start dialysis with a line in their neck, they're behind the 8 ball from day one. And we have not done them any favors by doing that. So if they have to start with a catheter, try to make it a PD catheter instead of a line in their neck.
Thank you. And I believe that our providers, our physician counterparts, are not adequately trained to do that. So these people crash into dialysis, and we know the catheter rates. I mean, it's actually very scary. So who's going to teach them to go to home therapies if they're starting with catheters because they weren't prepared in the first place? You're absolutely right. Where do we catch this patient population, and how do we nip it in the bud? And we haven't figured out the catheter thing, how we're going to figure this out. And I think there's opportunity there. I don't want to be, it's not all negative. I think there's a lot of opportunity there. It's just getting them at the right time with the right information so they can make the right decision for themselves.
And I think I would also say that that lends itself to new opportunities for nephrology nurses to catch these patients, to grab onto these patients earlier and to provide the information and education from a case management standpoint.
Care coordinators.
And transitions, yes, exactly, and transition and care. So I think when we look at this, we also recognize that there are going to be new opportunities for nephrology nurses in the future. And again, it is up to us to define what these potential roles are and to make ourselves heard, particularly as Lucy's alluding to here when we speak about the important educational role that we play. And I see that that really is probably the premier role that we will and have to play moving forward for any of this to be successful.
And how do we train our care coordinators and our case managers that are already in these jobs that don't know care of the kidney patient?
And ensure that the policy supports that and that it's valued as well. That's not something that just comes about. It's something that needs to be valued and paid for and invested in.
So on that note, one thing we all have to be challenged at, I am a pre-dialysis coordinator. We need to get more active in our communities. Go out and talk to people who don't know what dialysis is. Educate them. We also can talk about modalities at that time. Because most people have a family member that's out there. And if we're the first line and we're the trustworthy people, then we are the ones who have to get this started. So maybe we can prevent them from going on dialysis or lengthening their time before they get there and keep these initiatives at a rate where we can help control this. We are the educators. We are the healthcare person that they look to. My challenge is to everybody, go home, go to the schools, go to your council meetings, and start pushing this, because we can't change anything unless we start at ground level. And once they get to CKD stages and providers don't recognize it, these are our patients that are in crisis. And teach people to learn what their disease process is. Because I have a nurse who came to me from home program, and she says, I never knew what their disease process was. I didn't know it was important. So what got them there is something important that we all need to remember, because each person has a different process that got them there. So my challenge is go out and educate your communities.
Thank you.
Just one comment. You briefly touched on the reimbursement to providers and the negative impact, and that was something that was mentioned in a meeting I recently went to. the disincentive if you're not going to be able to meet some of the metrics? And where is the safety net going to be for those patients that physicians may say, I don't want them. You know, I can't meet the metric of getting this person home. They're my drug user. They're my homeless. What about the safety net for them?
There isn't one.
It's a concern.
Yes, absolutely.
And I would add to that as well, where's the safety net for nurse staffing?
Thank you. Thank you.
You spoke about patients who crash into dialysis and then they have no choice but to get a CVC. But we do have urgent start program. I work for a standalone home program, and we do get patients who crash into dialysis with PD catheters. It's called urgent start, and I don't know if that's a DaVita thing. I work for DaVita in Southern California. And we do get patients that we start them on their treatments. We can start them the very next day after their PD catheter is placed. And we do their treatments in the clinic while they're being trained. So, so I just wanted to put that out there, that patients who crash into dialysis can also be on PD.
And it goes to access to care. Does every program have that?
Right, and I think it's really important, this presidential directive is getting people talking about it.
Absolutely.
And so I don't know if our area is more progressive or as far as like for home therapies, but if, you know, this message or this directive from the president, I think has really gotten people talking about it, and maybe they'll be more educated on it.
Thank you.
Donna, you mentioned a little bit about nurses training, right? So I work in a physician-owned facility both in West Texas, and we have another facility in Hobbs, New Mexico. So one of the facilities in a remote kind of area. The challenge is the training for home modality. CMS is 3 months before nurses could train a PD patient. Texas has 6 months to train home PD patients. Nutritionists, it takes 1 year clinical experience before they can be a dietitian in your clinic. Social worker needs to have master's degree in order to qualify as a dialysis social worker. These are challenging, especially in big cities. Probably there are a lot of workers, but in remote areas, it's a challenge already to get one Spanish speaking with master's degree, with 1 year of clinical experience, with 12 months of nursing experience plus 6 months in a modality. So I think they need to reconsider some of their rules, especially to bend a little in some areas. I don't know if other big cities are affected with that too.
They're affected, but definitely not to the same degree. I mean, there's definitely a little bit larger pool, but yes, there are state regulations. Texas is one of them that it's even longer, and it's going to be a big issue, and people are going to be penalized because we don't have access to care, bottom line. If the nurses and programs aren't ready to take the patients.
And that's one of the points in our letters that we've brought forward as well, and we'll continue to bring forward. And I think many of our partners that we've been speaking to recognize these barriers as well.
And the rural areas are definitely an issue. So what are we going to do about it, or what can we do to support that?
Good morning. Thank you for the panel. My question is related to looking at outcomes. One of the things that you spoke on was increasing utilization of organs, particularly in transplant, and having more of our patients listed and transplanted. If we are moving towards using more organs, would we be looking at outcomes? Like suppose we start utilizing more organs, maybe they're marginal, maybe they're organs that would have been discarded, reducing the discard rate. If that starts to affect the transplant outcomes, how do we look at that and how do we reevaluate sort of where the line is there?
That goes back to unintended consequences.
Yeah.
Are we just putting a kidney in because it's like sitting on the table, we can use it? Those proposed rules haven't come out yet, so we will definitely be very concerned about that, making sure we pick the right patient for the right therapies, for the right outcomes. So yeah, it's a concern and we're going to be keeping an eye out for it.
Thank you.
Thank you.
Well, I'm glad she at least brought up something about transplant because I don't want to forget that piece. And coming from a transplant perspective, I just really strongly encourage everybody to refer your patients early. When we get patients referred to us who have been on dialysis 3, 4, 5+ years, we are already putting them behind the 8 ball. Because we know the longer somebody is on dialysis, the more comorbidities they have, and the less likely that they may potentially be a transplant candidate. So that early referral, preferably preemptively, is key to getting them a successful transplant and having them get an organ that will last them for years and years and years. So I just want to encourage everybody to please keep that in mind too.
Thank you.
Hi, I'm Claudia St. John. I've worked in an outpatient dialysis clinic for 11 years, and my whole time there has been, how can I keep people from getting in my chairs? And one of the things, I'm also the congregational health nurse for my church, and that is a good avenue for people who are interested in pre-dialysis screening to go to these congregational health nurses, see if anybody's having a health fair, and get involved with that health fair. I know our hospital in Lynchburg has a congregational health department, and they have coordinated congregational health nurses in many denominations. So that would be a good avenue for people to get into to help spread the word to get checked.
Oh, that's wonderful. Thank you.
And can I just add to that if anyone else has such services available to you in your community, either through your church or other, if you have a school of nursing nearby, maybe an excellent opportunity to expose those students to nephrology nursing.
Hi there, my name is Adam Wilson. I'm actually here from Edmonton, Canada, and so I've learned a lot in the last day or so. Just in regards to that education piece, like we're really lucky where I am as our program falls as a province and from the government, and so everything from CKD to GNC, we have all of these clinics that fall under the same umbrella. So we get referrals really quickly from our nephrologists, and we're able to start teaching our patients right away. So we have a renal insufficiency clinic that will start that education as soon as a patient's referred and while their GFR is high enough that they don't actually require treatment. And we work at getting them into a kidney choices class, which actually they sit down with a modality nurse. They have about 10 to 12 people, and they do a lot of really good teaching in the different types of modalities to start preparing our patients for, what is their disease progression going to look like? What are the options, for those treatments? And we really try to catch the people that we can get into a home modality, preferably PD, if at all possible, because we have a very rural population in northern Alberta. To put it in context, about the size of Montana. So that education piece and that referral piece, if you can get people to clinics quickly and give them realistic expectations of what their progression is and what treatments are out there, you might find some successes that way as well, which might really help. And so I just wanted to share that because I've learned a lot. I see like a bunch of different companies and different areas, and so that communication is like very key to getting some very successful outcomes for our patients. And our program in Alberta is actually the largest home program in all of Canada.
Wow,
so
thank you. Thank you for sharing
that
with us.
Thank you.
That's great. I think this is going to be our last comment because we're down to 45 seconds.
Okay,
It's been a
that's
very
fine.
healthy
I'm gonna make-
conversation.
We got a big timer up here.
Yeah, we do. It's red.
So I think 80%, as everyone else does here, is pretty ambitious, but as the nephrology population advocates, I think advocating for funding for the uninsured and the CKD population would greatly help. We often see that these patients, if we could get them to early referral for vascular placement, be in AV fistulas, grafts, or even buried PD catheters could help a lot. But there's a lot of uninsured patients who end up in dialysis, and at that point, I feel like they end up in center and...
Right, because then we have to wait the 90 days for them to be Medicare eligible.
Right.
Yeah.
And then at that point, they get complacent and they're like, well, someone does it for me.
Right.
My last thing is, I think surgeons too, we need to have more surgeons who know how to place PD catheters. We have a barrier in that.
Absolutely. Again, that access to care is going to be critical.
Yes, and unfortunately, me and my coworker, we see time and time again losing patients because the PD catheter didn't work and they just lose any kind of connection to wanting to do this.
Wow, unfortunate. Thank you so much.
Thank you. Well, that concludes our session. Thank you so much for your attention, attendance, and also the lively discussion at the end.